right, 5 o'clock on the dot, so we'll go ahead and get started. So this is our first in the new SATA Vanguard expert lecture series. We're going to do quarterly lectures on a specific topic, kind of focused on both cardiac and thoracic transplant, as well as abdominal. And we're honored to have Dr. Ted Sakai here to do the first lecture. He earned his MD in 1989 and PhD in 2001 in cardiovascular surgery from Kyoto University in Japan. Then went on to complete a cardiovascular surgery residency in 1995 in Japan as well, and then became board certified cardiovascular surgeon. And then came over to the University of Toronto and completed both clinical and research cardiovascular fellowships before relocating to Pittsburgh as a visiting instructor in their thoracic transplant surgery program in 1999. And then he moved over to the dark side and joined anesthesia and completed his anesthesia residency at UPMC in 2005 and joined the faculty thereafter. Was promoted to associate professor in 2010 and then full professor in 2014. Has over 100 peer-reviewed publications on numerous topics covering liver transplant anesthesiology and a lot of articles covering anesthesia education as well. He's recognized as one of the leaders in transplant anesthesiology and is the president-elect for the Society of the Advancement of Transplant Anesthesia. Was a co-editor of a comprehensive transplant anesthesia textbook entitled Anesthesia and Perioperative Care for Organ Transplantation in 2017. And he's nationally recognized as an anesthesia educator as well. He's received the Distinguished Educator in Anesthesiology Award from the ASA and the Society for Education in Anesthesia in 2019, and serves as the chair of the SEA Research Committee as well. He's also elected to the Association of University Anesthesiologists in 2013. So as you can see, lots of accomplishments. We're very excited to have him speak today on living donor liver transplant, particularly donor management. So won't take up any more of his time and I'll let him get going.
All right. Thank you very much, Kara. Very nice introduction. And thank you very much for the organization committee of the Vanguard committee, especially. And then to provide me the chance to talk about the one of the topic of my interest. So coming 45 minutes, I'm going to cover the update of the donor management in live donor liver transplantation. Hold on a sec. So disclosure-wise, I have a textbook, Royalty, Springer Inc., but that's the only one. And then there's no influence of this disclosure to this current topic. So this is a beautiful picture, as you can see. Often the magic you witness every day when you get involved for the live donor liver transplantation. Left side is the uncle who received a part of the right liver graft from the person here. So today I'm going to discuss about only the donor. I'm not going to talk about any recipient issue. So in the world, live donor liver transplantation is increasing in number. For example, one with the premier institution, Assam Medical Center, as you can see that exponential increase of the live donor liver transplantation in the year 2000. And then currently, this is a relatively old figure, and then I couldn't find the recent national figure. Korean society doesn't have those UNOS equivalent or SRTR equivalent data in the country, as far as I know. So I do not have the most recent number, but this is the kind of significant trend, especially in the Asian country where donation after the cardiac donation after the brain death is quite rare. So how about in the United States? It's a mediocre increase, and then there's no increase exponentially. The live donor liver transplantation started in 1989 when I graduated medical school. That's the pediatric, adult to pediatric liver transplantation. And then first adult to adult live donor liver transplantation was performed 10 years later, 1998. And then a trend itself is stifled. So most recent 2019 SRTR data shows we performed the, close to 8,800 liver transplantations. But live donor liver transplantation is only the marginal 5.9%. In the United States, 500 plus cases performed. Even though there's some increase from the 2018, but still number per se is quite small. However, a live donor liver transplantation is very important. Why? Because there are so many waiting list, and then only the limited number of liver transplantation can be performed because of the limitation of the deceased donor liver availability in the United States particular. Therefore, we have to provide the chance for those people who has the potential to receive the live donor while you are waiting. Currently, we have 82 live donor liver transplantation program among the 147 liver transplantation programs in the United States. So this UNOS allocation, 11 regional allocation system is passé right now. However, just for the benefit of the explanation, I will use this one for the region. And then as you can see, all the region has at least one institution performing the live donor liver transplantation. My prediction is that probably this trend will be increased. So in your neighbor or in your program, I'm sure a lot of hepatic transplantation programs interested in to institute the live donor liver transplantation. Therefore, we as the anesthesiologist team has to be prepared. So coming 45 minutes, I would like to cover 5 areas here. I'm talking about the donor surgical outcome utilizing the A2O study and current literature review. And then followed by donor pain outcome. It's not a surgical outcome, but the pain-focused outcome. The landmark paper has been published in the A2O study, so I'm going to show that. And then, so we're talking about the comparison of the original technique. This is our area of expertise. So what kind of anesthetic management is best served to mitigate the pain, especially development of the chronic surgical pain. And then we move on to the ERAS in donor management. And then, so ERAS is almost universal in any center, but we at the UPMC adopt the ERAS protocol probably in the earliest institution in the United States. And then lastly, I have to touch upon the potential impact of minimally invasive donor surgery. So total laparoscopic surgery is in your institution or has to in the future. So we'll talk about the impact, especially for the post-surgical pain. So donor outcome. First of all, everybody who get involved for the live donor liver transplantation program has to get accustomed to the history, especially in the A2O study. This is the adult to adult live donor liver transplantation cohort study, which funded by NIH since 2002. When you remember, the adult to adult live donor liver transplantation started 1998. So this is the initial concerted effort among those institutions who started the adult to adult live donor liver transplantation. But anyway, so this is the first multi-center consortium aimed at providing accurate information on the outcome for both donors and recipients who undergoing the adult live donor liver transplantation. So there are 2 phases in the history. A201 phase is the beginning one enrolled between the January 1st, 1998 to the 2009. So 9 North American liver transplant centers get involved. And then A2O phase 2 study is starting the continuum for the next month, September 1st in 2009, up until January 31st, 2014, which of course, including the long-term follow-up of the A2O1 phase study patients. They increase the number of participants, and then in total, 12 centers get involved in the A2 phase 2 study. So how many numbers of recipient donors they collected, which is close to 2,700 donors and then 2,100 recipients. And then it's remarkable when you check the A2O as a keyword, you can pick up the 41 publications so far. So when you, this is one of the significant concerted effort prospectively designed to collect all the data of the adult to adult live donor liver transplantation, both recipient and donors. So how about the surgical outcome? Dr. Abekasius, who was the chief of the Northwestern, and then who is the head of the 2012 study, including the 740 donors, and then as high as 40% of the donor had complications, which include 296 donors experienced the 557 complications, including 0.4% of mortality, as you can see here. So what are the breakdown of those complications? And first of all, bacterial infection, followed by biliary complications. Those are the two big complications associated with the donor hepatectomy. And then including additional complications, as you can see, intraoperative complications, various stuff, incisional hernia, often they have to come back to the surgery, pleural effusion, psychological difficulties, and re-exploration, most likely the bleeding. So those are the surgical outcome. 40% of the initial cohort of the donors suffer a surgical outcome. And then often pain is neglected. But how about the pain outcome? So among the A2O study, this is a relatively later publication. So year 2018, A2O group provide the fatigue, pain, other physical symptoms of live donor liver transplantation. And then it's very nice to see our president of the SADA, Dr. Susan Mandel, is one of the co-author of this important paper. So they follow up the not only the acute pain, but the long-term pain outcome. So 3 months, 6 months, and then up to 2 years after the donation. And then they collectively follow up the patient and then ask the pain and then other life, daily limitation. So as you can see, at the 3rd month after the donation, 12.8% of the patient complain significant pain, which define more than a 4 out of 11 pain scale. And then 2 years after the donation, still 7.9% of the patient complain more than a 4 grade pain. So, which means that these patients who come here, volunteered the live donor liver transplantation suffer significant amount of pain as long as 2 years. Other study published the 2014 also demonstrated the significant impact of the chronic pain for those donations. This is the single institution study. It's small, around the 65 donor hepatectomies involved between 2003 and 2008 in the Toronto General Hospital. These patients are treated either IVPCA or thoracic epidural. But anyway, so moderate to severe level of pain, which defined the same way, more than a 4, equal or more than a 4 among the 11 Likert scale, and then a significant percentage of the patient experience the resting and also after the movement pain. How about the chronic stage? They collected the data, even though it's small in number, but around 31% of the donor at the 6 months. And then at 1 year, still 27% of the donor experience the chronic pain, which is breakdown for the abdominal, incisional site, the back, rib cage, especially in the right-sided. Probably its influence or impact of the retractor during the surgery. So this is important stuff we have to address, which is a chronic post-surgical pain. So how have we tried to mitigate CPSP, especially those donors? By the way, chronic post-surgical pain, CPSP, defined with the 4 conditions. One is that the pain must develop after the surgical procedure. The pain is of at least 3 months duration. Other causes of the pain has to be excluded, and a possibility of the pain is from the pre-existing condition has been excluded. Okay, so this is the definition of the chronic post-surgical pain. So a lot of factors influence the development of the chronic post-surgical pain. As you know, age, genetics, especially in the psychology before the surgery impact the development of the acute post-surgical pain, which may lead to the development of chronic post-surgical pain. Psychology, including the level of anxiety, depression, catastrophizing before the surgery. So this is the kind of psychological propensity towards the development of the acute as well as chronic pain. However, the surgeon inflict the surgical stress, so a surgical technique matters. And then we, as the anesthesiologist, can mitigate the pain, potentially acute pain, especially with our anesthetic technique, which include regional block and also adjuvant therapies. So how's the acute pain management influence this development of CPSP? Seems like the management is so important in the acute phase to decrease the development of the CPSP. So one of the cohort study, in this case, adult thoracotomy patient, that's the one of the most painful surgery among all the surgical incision. It's a small study, 131 patients get involved, 6-month follow-up. And then 39% of the patient developed a chronic persistent pain. So predictors is mainly the pre-operative pain. So thoracic pain for 3 months pre-operatively, odds ratio more than 3. Thoracic pain for 12 months pre-operatively, odds ratio is close to 3. But most importantly, the higher pain score at rest in the first 5 post-operative days compared to the patient without chronic persistent pain, increasing to 79%. So acute pain management matters. So what kind of modality do we have for those truncal surgery, especially in the liver? We have regional anesthesia versus IBPCA, and then gold standard is considered to be still on the thoracic epidural. However, other regional technique is tested. Bilateral paravertebral block, and then continuous wound infiltration. The spinal, either a one shot or continuous, and also multi block, medial open transversus abdominal spleen, and also QL block, quadratus lumborum block. I'm not a regional anesthesiologist. I'm not try to pretend that being, but those are the reported options, especially for those abdominal surgery. What kind of adjuvant analgesics? We have IV lidocaine, we have IV ketamine, we have acetaminophen, PO or IV, and then COX-2 inhibitors still available. And also we have gabapentin or gabapentinoids, especially for those chronic pain or conditions. So let's focus on the regional. How about a comparison of the regional technique? Is there any alternative compared to the thoracic epidural reported to be effective in the acute pain management, especially for liver surgery? So seems like thoracic epidural is better than a simple IVPCA. Cochrane review type report was published in 2016 ANA, which wrap up 60 years of the history and then a publication. They find 22 trials which featuring the 1,100 more patients. And then in there, they compare the epidural containing local anesthetics, whether without addition of the opioid versus IVPCA. It seems like thoracic epidural is better than IVPCA in the sense that accelerates the return of the GI tract transit, which has the high quality of evidence, meaning that maybe more than 2 randomized controlled trials demonstrated the benefit of the thoracic epidural over IVPCA. Also, decreased pain after an abdominal surgery. This is moderate quality of evidence, and then probably not 1 randomized controlled trial. And then it does not affect the incidence of vomiting or anastomotic leak, although the quality of the evidence is low. And then for an open surgery, an epidural containing local anesthetic would reduce the length of hospital stay, despite a very low quality of evidence. But overall, our intuition is agreed to this review. Thoracic epidural for abdominal surgery is better than a PCA in the various kind of outcome, including the decrease in the pain after the surgery. You may ask, okay, so right-sided hepatic lobe donation, is it safe, especially for the coagulation standpoint of view? Seems like the thoracic epidural for donor hepatectomy seems to be safe. So this is a small study, but 104 patients undergoing the thoracic epidural for the right lobe liver donation. And then none had VAS over 5 during the study period. And then there's no delay in removal of the epidural catheter based on the ASRA guideline. And then a majority had a catheter removed by postoperative day 4. And then usually in 72 hours or after, the inoculation of the bacteria of the catheter site is increased. So day 4 is the day to remove the thoracic epidural catheter. So there's no delay due to the prolongation of the INR you can see on the right side panel or decrease of the platelet. So there's no incidence of epidural hematoma, even though the epidural hematoma itself is very low incidence. In order to prove that, you need 1,000 thoracic epidural. This is only 104. So your question is that which regional technique is better compared to the thoracic epidural? Considering the thoracic epidural is the gold standard. As we discussed, at least we have 5 options available. And then I tried to find out via some good randomized control trial, but the evidence is quite limited. So how about the epidural versus bilateral paravertebral block for the liver resection? So this is the one with the study we performed and then published in 2016 at the UPMC. This is the randomized prospective open label study, including adult patients undergoing the elective open liver resection, including cancer. It's none of the live donor is included here. And then we have 41 thoracic epidural, and then a 39 bilateral peripheral block. And then using the straight local anesthetics without having the opioid, infusing the 3 days, and then with the addition of the IVPCA. So given that study, no catheter-related complications were noted. And the primary outcome, which is the 24 hours after the surgery VAS score with incentive spirometer, there's a significantly lower in the thoracic epidural group compared to the bilateral peripheral block. So as you can see, it's clinically less meaningful because the difference is only 1, but statistically significantly decreased with the usage of a thoracic epidural compared to the bilateral peripheral block. How about continuous wound infiltration compared to epidural? And then this is the open liver resection study, which published in 2015. Randomized control, continuous wound infiltration versus thoracic epidural, which is used up to 48 hours after the surgery. And the primary outcome is not pain, rather functional recovery. And then there's a significant difference between the thoracic epidural, and then continuous wound infiltration has the better or sooner recovery time after the surgery. Pain score itself, there's no significant difference between the two. So continuous wound infiltration seems to be a good alternative to the epidural. How about the spinal? We only have a continuous spinal, and then not on liver, but in general abdominal cancer surgery. A small randomized controlled trial, 25 and 25. And then based on this, there's no significant difference in terms of the pain, but the pain management is quite good in both groups. So at least thoracic epidural is comparable. Well, the bilateral peripheral block is not necessarily up to the thoracic epidural, but continuous wound infiltration and also continuous spinal, at least, are reported to be equivalent in the effect of the recovery and the pain management for the abdominal surgery with the thoracic epidural group. There's no good report of the bolt-up versus epidural, nor a QL block versus epidural. So wait to see what kind of a study will come up. So ERAS protocol. Our pain management certainly lead to the ERAS protocol, and then just kind of review the ERAS. Historically, it's developed in Europe in the 1990s by the surgeon named Henrik Carrot. He's a GI surgeon in Copenhagen, Denmark. And then he developed the protocol, a perioperative clinical protocol model that included implementation of the 20 to 24 relatively clearly defined and rigid protocol. And then implementation of which synergistically decreased the surgical stress and translated into the enhanced recovery after the surgery. So ASA wholeheartedly embraced the concept. ASA Monitor published this in 2018, which feature those 24 items in the summary, like this: in the preoperative consideration, optimization of the comorbid conditions, avoidance of prolonged preoperative fasting, prehabilitation, which is the very, very important topic nowadays for the liver transplantation, patient and family education, counseling, discharge planning, so anticipation management of the patient and also family member. Intraoperatively, utilization of the fast track anesthesia technique, a procedure in a patient-specific multimodal opioid-sparing pain management. Opioid sparing is very important nowadays. And a multimodal antiemetic prophylaxis, avoidance of fluid overload, lung protection, mechanical inhalation, maintenance, non-thermia, antibiotics, and then venous thromboembolism prophylaxis. Post-operatively, early oral feeding, and then early post-op mobilization of physical therapy. So those ERAS protocol would improve the patient satisfaction and then improve the post-operative outcomes, a decrease length of stay, and then a decrease risk of hospital-acquired infection. So there are a lot of papers published for the effectiveness of the ERAS protocol for various kinds of surgical intervention. So how about the liver? So the knee and also other Chinese co-authors published in 2015 for the meta-analysis for the effectiveness of the ERAS for hepatectomy. So they identify 5 RCTs featuring 723 patients, and then a majority of them because of the cancer. And then they compare the ERAS group, 344, and then traditional care, 369. So what they found was that ERAS program were associated with a significant decrease of overall complications, a 34% decrease. And then a hospital length of stay, significant here. And the time to first flatus, so recovery of the GI function, is close to 1 day with the usage of the ERAS protocol compared to traditional care. So ERAS protocols work for the liver resection. And then the basics of the ERAS pain management is combination of regional and also adjuvant analgesics. Okay? And then addition of those adjuvant analgesics on top of the one choice of the regional is the mainstay of the ERAS pain management. So let me introduce the ERAS system in the UPMC. And then before the 2016, we do not have ERAS at all. But with the arrival of the new junior faculty members, both the anesthesia and also colon cancer actually changed the UPMC as a whole. So Stefan Esper, who is the assistant professor of the cardiac anesthesiology division, graduated from the UPMC and spent 1 year in the Duke University for the cardiothoracic anesthesia fellowship. He learned how the ERAS adopted in Duke, and then come back to the UPMC and then initiate the ERAS protocol, along with the junior surgeon around that time who arrived here from Mayo Clinic, Jennifer Holder Murray. And then those two assistant professors actually started the ERAS movement. Now, after a couple of years, at the currently in the UPMC, every surgical line has their own ERAS protocol in a system. So the liver donor surgery also adopt the ERAS protocol. And then initial experience was published in 2018 by the surgical team and not have the heavy input from the anesthesia team. I have to say that. And then, so they compare historical cohort of the pre-ERAS live donor liver transplantation donors versus ERAS group, 30 versus 30. So all donors had the same incision by the chief surgeon, because Dr. Humar, who is in chief of the hepatic transplantation, performed the all donor surgery by himself. So there's no alteration historically compared to the pre-ERAS and then post-ERAS protocol group. So ERAS component, especially for the pain, is consistent with this in the pre-operative and especially in the intrathecal injection of morphine. And we adopt this as the sole regional technique for the live donors. Intraoperatively, we utilize the ketamine continuous infusion along with the IV lidocaine infusion. And also surgical team use the liposomal marking for the surgical site local injection. And post-operatively, we use the IV ketamine continuous infusion, then IV lidocaine continuous infusion up to 48 hours. I have to note that there's significant modification of the ERAS protocol. I'm going to explain that most modern protocol later. But during that study period, especially in the beginning, we adopt everything in a heavy manner. IV ketorolac utilized, then PU acetaminophen, and also NSAIDs is in place. So pre-ERAS pain management was mainly by IV PCA without any regional technique, and then without any concerted effort of the adjuvant. So the young donors, and then male, female, same allocation, mainly the right road. And then what are the pain outcome? So ERAS group has a significant decrease of the pain scale, 11 pain scale, as you can see in the y-axis, at the first day, second day, and the third day. Clinically significant and statistically significant decrease of the pain. And then, so this is a surrogated marker of the pain usage of the opioid converted to the morphine equivalent during the hospital stay. As you can see, the ERAS group has the significant reduction of the total requirement of the opioid during the acute post-surgical period. Average hospital stay is no difference. 6 days in the pre-ERAS, and then 5.7 days, and then ERAS. But again, because of the concern for the safety, we have not implemented the expedited discharge system. So probably that's part of the reason that there's no difference here. But if we evaluate about the preparedness of the discharge, the history, the things might be different. So ERAS for live donor surgery is effective. So let me just kind of quickly touch upon the current ERAS protocol, the live donor surgery. So we have a surgical clinic, and then every donor will be seen by the anesthesiologist at the pre-operative clinic. Then so general explanation is done. And then risk identification is performed, and then a mitigation of any chronic modifiable factors will be adjusted. Prehabilitation is recommended. And then most important part is that the pharmacological intervention, pre-op holding on the day of surgery. Gabapentin was provided, and then COX-2 inhibitors, PO, provided. And also, if the patient cannot have the intrathecal morphine, and then long-acting morphine equivalent is provided orally. And then during the surgery, intrathecal morphine is the mainstay. And then you would be surprised to find 500 microgram of intrathecal morphine was provided for the routine practice. This is based on the safety is guaranteed after the surgery. All the patient is going to stay in the TQ, transplant ICU overnight. There's a argument about the seating effect. 200 or 250 mics is the maximum intrathecal morphine dosage to achieve the maximum analgesia. However, that particular finding is based on the gynecological or pregnancy for the pregnant patient population. So in general population, we have a tendency to use the higher dosage. Maintenance ketamine IV drip, 0.4 milligram per K, and the ideal body weight until the liver is resected. So with the lidocaine continuous drip, 1 milligram per K per hour. And then at the time of emergence, stop lidocaine, give the acetaminophen, ketorolac at the skin closure. And then post the same day, we continue the ketamine drip in the 72 hours after the extubation of the patient and the transfer of the patient to the ICU. Hydromorphone was used for the breakthrough pain management. Gabapentin is started. And then we have the significant protocol about the opioid requirement breakdown. And day 2 and day 4, we continue the transit. We will see the transition of the lidocaine drip to the acetaminophen. So finally, I will touch upon the potential impact of the minimally invasive donor surgery. So as we review in the past, in the previous three, anesthesia technique is important, which we discuss about right now. But how about the surgical technique? The minimally invasive surgical technique is important for the various kind of surgery. How about the live donor liver transplantation donor surgery? So minimally invasive technique has been actually utilized. Open subcostal incision, midline incision. This is the traditional manner, still in the UPMC, and as well as majority of the institution in the United States. But some of the institution advocated using the minimally invasive technique, starting the hand-assisted laparoscopic procedure. And then funnel steel incision has to be used for the removal of the right-sided liver segment. And then moving on to the total laparoscopic, with or without robotic, that's the kind of the most, minimally invasive approach, among others. So funnel steel incision is the OB gynecology incision, as you can see here, and rectus abdominis is preserved. So that's the reason the recovery is better. So laparoscopic donor liver resection, what's the history? First series of live donor liver transplantation using the left lobe allograft obtained laparoscopically was reported as early as 2013. In 2017, early series of total laparoscopic right lobe living donor hepatectomy was reported. But the majority of the surgeon during that time reported the operation time was longer than the open. Length of stay and complication rate were similar, but they required a steep learning curve. So any premature attempts to doing the total laparoscopic for those right live donor liver transplantation donor surgery lead to a surgical disaster and a donor mortality. So they actually cautious caution, give the caution among the surgical specialty. However, year 2018, we see this significant report, 115 cases of pure laparoscopic live donor right hepatectomy was performed at the Seoul National University. So as you can see, that a significant increase of the total laparoscopic hepatectomy, and then majority of the patient is the right side liver donation. So this is quite eye-opening. And then, last year, we see that significant study published from the group from King Faisal, a specialist hospital, the Saudi Arabia. The surgical team is the team from Germany and also United States, but they practice in the King Faisal hospital. Anyway, so they reported the propensity matched analysis of the robotic right lobe donor hepatectomy, a 35 patient, versus open right lobe donor hepatectomy, 1:2 ratio of the propensity matching. What they found was that operating time is longer in the laparoscopic manner compared to the open. 500 minutes required versus 330 minutes for the open. But they demonstrated that a significant decrease with the number of the patients, increased. So among 263 consecutive adults, and then by the way, they performed the 4-year period. So first, warm ischemia time was longer and the blood loss significantly less in the total laparoscopic. So overall donor complication was similar, 6% versus 17%, even though there's the trend towards the decrease in the total laparoscopic compared to the open, but that has not reached the statistical significance given the small, number of patients. How about the pain? This is the kind of our interest. And then as we expect that total laparoscopic robotic manner is better than open. So PCA usage is 0 in the 35 patients who undergoing the total laparoscopic, while the 73% of the people required IBPCA for the adjunct. Length of stay is significantly decreased with the total laparoscopic compared to the open. So robotic surgery is quite impactful as the minimally invasive surgeries often do compared to the open. So there's more increasing number of institutions, even in the United States, would adopt the totally laparoscopic donor surgery for the live donor liver transplantation. So in summary, live donor liver transplantation is increasing in number even in the United States. And the post-surgical chronic pain of liver donor surgery should be prevented because this is a significant burden for those donors long-term. Regional technique often, other than a thoracic epidural are available, and then it seems like effective, even though the evidence level itself is low. ERAS protocol for the liver donor has been developed and then demonstrated its usefulness, and then including the UPMC system. And then finally, minimally invasive donor hepatectomy is feasible and demonstrated the significant reduction of the post-surgical pain, thus the better outcome. So thank you very much for your time, and then close here.
All right, thank you so much. If anybody has any questions, I guess if you want to ask them, since we're not in a webinar and it's actually a meeting, anyone can feel free to jump in and ask questions. We did have one from the chat box about methadone use in a lot of ERAS protocols for open abdominal procedures, and was wondering if you could speak to the pros and cons of preoperative IV methadone use if you can't do neuraxial techniques.
I think that's a great idea. The IV formula of the methadone, 20 and 30 milligram, especially for those people who has a chronic pain condition, is proven to be useful. And then not so many the patient population has the chronic pain before the surgery. So that's the reason we still stick with the MS content style, the PO opioid. But certainly with the kind of proper dosage, and then that may equivalent or maybe superior approach if we cannot do the regional. So I agree with that. That's a great suggestion.
Thank you. We have another question. Wondering if you have come across any studies, or if UPMC regularly utilizes erector spinae plane blocks. We've tried these at our institution in Colorado a couple times, given the decreased issues with worrying about coagulopathy and things like that. So have you seen that start to pop up as an alternative to neuraxial techniques?
I do not have a personal experience about the particular regional technique, But I know that for the pediatric, the recipient side, and then some of the faculty, the regional faculty, get involved for the acute pain management for pediatric population, and then utilizing the quadratus lumborum block. And then it seems like it's feasible, and then actually performed for the multivisceral and liver transplantation. But adult population, we have other alternative at this moment. Spinal is the 95% or more a theoretical chance of the safe delivery, and then failure rate is small, effectiveness is significantly proven. In that case, we are no intention to move away from the spinal at this moment.
All right. And then any comments about lidocaine toxicity after a hepatectomy, especially, I guess, if you're taking a large portion of the liver out, given the pathways may not function as well?
Yeah, this is our experience, actually. As I mentioned, that the initial study group, actually, we overutilized the dosage of the lidocaine. And then indeed, relatively in an older population, if the donor age is probably in 50, then if that's the case, you may see that significant lidocaine toxicity. And then, of course, we check the lidocaine level every day. But given that experience about the several cases of the lidocaine toxicity, and then we decrease the dosage, and also, but still, the benefit of the using the lidocaine drip is significant. So as long as you monitor the patient consciousness, and then especially in the ICU overnight, that may kind of provide the safety net for the usage of the IV lidocaine. But totally agree, the usage of the lidocaine, the huge dosage in a continuous manner pose the threat for the lidocaine toxicity of those donors, even though they are healthy.
I guess along those same lines, I was wondering about just over-sedation with narcotics, given their recent hepatectomy and the fact that most of the donors are fairly healthy and opioid naive.
So that's the reason we try to limit the usage of the opioid, especially in a parental opioid. And then so spinal opioid 500 mics, and then probably that's the most important factor to lead the success personally and then group-wise experiencing right now in the UPMC. We tried the thoracic epidural as the pain modality and regional modality, but the failure rate is significant. And then so technically, sometimes we fail. So compared to that, spinal opioid is easy to administer, and then it seems like it works quite well. And then so that will lead to the decrease of the usage of the IV-PCA. Then so in total, as our report demonstrated to you, a conversion of the morphine equivalent during the hospitalization compared to the traditional group, the spinal opioid included group, which is the UPMC ERAS protocol, actually significantly reduce the requirement or usage of the opioid after the surgery for the donor.
All right. Another question about anticoagulation used during the living donor patients during the perioperative period. It looks like University of Wisconsin is using enoxaparin, which eliminates their ability to do a thoracic epidural.
That's a good question. I do not have that in my mind. And then so GI procedure and then preoperative heparin sub-Q is utilized, and then SCD during the case. And then so I have to go back to the protocol and check whether the patient received such kind of sub-Q heparin. But as far as I know, we do not engage those anticoagulation regimen, which prohibit us to engage neuroaxial for the donor at the time of the surgery. And then so it's important to prevent that the DVT and so forth. But I think the benefit to provide the neuroaxial in the form of the spinal opioid actually, outweigh the importance compared to the prohibiting anticoagulation method.
All right. Another question about just confirming the surgical technique used at your institution when reviewing your data on the regional techniques. It's the fully open procedure, yes. Is that correct?
Fully open procedure. And then a surgical team want to preserve the rectus abdominis. And then so surgeon is quite skillful to using the hockey stick and then without severing the rectus abdominis on the right side. So this actually improved the rehab of the donor, but still it's open approach. I know Tufts Lehigh University Institute, led by Michael Kaufman, the surgeon is doing the total laparoscopic for the donor hepatectomy. That's the only institution, as far as I know, in the United States, apply that technique regularly.
All right, and then another question from the chat box. How soon after surgery do your liver donors get up and start to walk around?
Next day. So which means that day one, they start walking around, especially ambulation, I should say, for the going to the restroom, and then so. But post-op rehabilitation should be very aggressive.
And then I think one more, just overview on preoperative gabapentin. Any dose recommendations?
Yes, 600 milligram PO, and then that's I think, and then there's of course reduction is required if the patient age more than 60. I think I have to go back to the protocol, and then if you send me the request, I can share the protocol, the UPMC ERAS.
All right, I think that's all the questions in the chat box. I don't see any more. Well, I just wanted to thank
Kara. Kara,
yeah,
one question was sent to me in by mistake directly. So
yeah.
Ted, if you could just, I was trying to copy it, but it wasn't working into the chat. So just Ted, could you comment on if you do a lot more left donor lobectomies versus right lobe donor nephrectomies, and what do you feel about any particular comment on the Korean experience with donor surgeries? This was one of the questions that was asked.
Let me clarify your question. So comparison of the right, left side of the hepatectomy?
Oh no, just in general. Well, what do you do more at your in terms of donors? Do you take more right lobes or left lobes at your center?
Oh,
yeah,
so,
that's the question.
Yeah, and then majority of the cases adult to adult, meaning that right hepatectomy is the donor surgery we are kind of dealing with day by day. And then, so initial report, which is, I believe, 30 cases in each arm, and then majority, 26 or 4 cases at the right, and then only 5 or 6 cases are left. So probably that's the ratio is still stands at this moment.
All right. Thank you to Dr. Ted Sakai for that fantastic lecture, and thank you to everyone for joining in. Great discussion. We're going to continue to try to have these Vanguard expert lectures quarterly on a variety of topics, mixing in both cardiac and abdominal transplant for talks in the future. Tentatively, our next talk, we're planning to try to do that in June of 2021. More details on that to follow. So that's all we have. Thank you all for joining.
Thank you very much for your time.